Based on, sir, your recent talk in the CSI 2017, which is on the functional mitral regurgitation in ischemic heart disease, so we would like to know from you how common this functional mitral regurgitation is.
Right. This is an important topic actually. We have such a large population of ischemic heart disease patients in India, and a lot of them have left ventricular dysfunction. Now, in the patients of ischemic heart disease with left ventricular dysfunction, some degree of MR will be observed in almost 30% of the people. Now, it is important to realize that people with MR have inferior prognosis as compared to people without MR. Third important point is that the mitral regurgitation in ischemic heart disease is not a valvular disease. This is a disease of the ventricle, and it is basically because of the changes in the ventricular geometry. So we need a separate assessment of mitral regurgitation in ischemic heart disease because it has impact on the therapy.
Right, sir. So, sir, do you think that there are some challenges in assessing the ischemic mitral regurgitation, and will echo has any place as far as the diagnosis is concerned, and do we need to take some extra efforts for that?
Right. So echo basically remains the most commonly used modality, but the point is common parameters of mitral regurgitation are inadequate to give complete information about the functional, or which is nowadays called as secondary MR. Since the valve is normal, as I mentioned earlier, we need to concentrate more on the displacement of the papillary muscles, and we also need to calculate what is called as stenting area. Stenting area is the area which is subtended by the mitral leaflets with the mitral annulus. Larger the stenting area, higher are the chances of having MR and MR recurrence after the procedure. We can also measure multiple parameters which tell us about the displacement of the papillary muscle, namely the posterior displacement, the lateral displacement, and the apical displacement. And depending upon the displacement, there may be therapeutic options which eventually will emerge, which should be applied in particular type of displacements. Now, depending upon the displacement, you have typical phenotypes of this functional mitral regurg or secondary mitral regurg. The commonest phenotype is asymmetric mitral regurg, which is basically because of the infero-posterior myocardial infarction, posterior lateral displacement of the posterior papillary muscle, which causes stenting of the posterior mitral leaflet and a pseudo prolapse of anterior mitral leaflet. That gives typical eccentric jet MR, which is directed posterolaterally in the left atrium. Now, because this is a eccentric MR, it is very difficult to assess in severity. But when we apply multiple parameters of severity, we can easily come to a conclusion about the severity. The second phenotype is a central jet MR, which is more commonly seen in anterior wall myocardial infarctions or typically cases of dilated cardiomyopathy, where both the leaflets are pulled apically in the left ventricle and they fail to co-opt, and what you get is a central jet MR, but usually it is less severe as compared to the eccentric jet MR.
Okay, sir. So, sir, for managing such patients of functional MR in ischemic heart disease, what treatment modalities are available?
Right. So, if you look at the list of the treatments which are offered to these patients, it's a huge list that basically tells us that none of the therapy works well in this particular subset. Commonly offered therapy is medical therapy, which is offered to almost 75% patients of ischemic mitral regurg. But European Society of Cardiology gives class A recommendation for combined revascularization and mitral valve repair if the ejection fraction is more than 30%. Question comes if the ejection fraction is less than 30%, here the operative mortality is more, and therefore most of the surgeons refrain from combining coronary procedure with a mitral valve repair procedure. Percutaneous edge-to-edge repair by MitraClip is offered to some of these patients, and you see that in Everest 2 trial, around 30% patients, one third of the patients which were included in Everest 2 trial, which is a trial of mitra clip or percutaneous edge-to-edge repair, were of functional mitral regurg. However, the results were definitely inferior to the mitral valve surgery as far as the outcomes of mitral regurgitation quantity is concerned. Further, mitral valve surgery was able to reduce mitral valve regurg more significantly as compared to mitra clip. There is also a debate about whether mitral valve repair is better or mitral valve replacement is better. And to answer this question, Cardiothoracic Surgery Network did a randomized trial. What they found was mitral valve repair and replacement both performed equivalent at the end of 1 year, but recurrence of mitral regurg was seen in almost 30% patients of mitral valve repair, which was not seen in patients of mitral valve replacement. And therefore, if the surgeon is not very comfortable with repair, mitral valve replacement is also a very durable option in these patients. There are some novel devices which are being tried here. Amongst them, there are some percutaneous devices which are put through the coronary sinus, which are called as cinching devices, which constrict the posterior mitral annulus and help coaptation of mitral leaflet. But the data on all these devices is very limited and they are in the very early stage of development. So practically what we have is medical therapy, revascularization combined with a mitral valve procedure, which could be either mitral valve repair, replacement, caudal cutting procedure, or edge-to-edge repair of the mitral valve.
Right, sir. So, sir, based on your huge experience in the cardiology, do you think that the Indian cardiologists are in line with the ESC recommendations, or they follow some kind of modified treatment modalities, or based on the case-to-case basis?
Well, I'm sure most of our cardiologists are aware about the guidelines. There is no question about it. Point is how much of it translates into clinical practice, and there I guess it is an individualized treatment which is offered depending upon the choices of the doctors, expertise available locally, and the possibilities with the patient, because as you are aware, most of our patients are spending the money out of their own pockets for their treatment. So all these things have to fit in to offer any kind of therapy. As far as awareness about the guidelines is concerned, I think most of our colleagues are very good at it.